We are going into a recall session, the recall session for NEET-PG 2024, conducted on the 11th of August. In this particular exam also, the crux of the matter is how you handle the pressure. Because if you ask me, how is this exam different from the ones that we have had? Let me just try to make these things very clear. We have had exams like this ever since even I have written an exam like this. All of us have written exams like this up to 2020. 2020 Jan was the last of an exam of this kind, which was in fact a bit more difficult because we had 300 questions to answer in 3.5 hours. But post-COVID, due to some reason, we of course did not have an exam for a long time. When the exams resumed in 2021 September, we had a very easy paper and the same pattern one-liner paper, which you can actually kind of answer and get a reasonable score with these revision strategies and a lot of notes and all that. That was the way in 21, 22 and to an extent in 23. 23 was relatively moderate, but you could get away with that. But now from 24, they have just gone back to the old format. They've just gone back to the old format. I'm not sure whether the governing body has changed or the question paper setting body has changed. I'm not sure about that. But definitely the pattern has gone back to the original format. Why people are actually getting confused is because many of the students preparing now are not aware of what is happening in 2020. So they have probably seen their seniors or maybe 2 years seniors who have not written the original pattern exam. So this original pattern exam, shooting becomes a very, very important part. Why it becomes a very important part is because even when I was writing the exam, we did not have these blocks. So 300 questions are there for us to see and go back to every single time. Now that's not the case. This is exactly like shooting, where you are having 40 questions, you are having 42 minutes and you are having to shoot, which is like this 25-meter air pistol event. In this 25-meter air pistol event also, you are basically getting blocks. Inside these blocks, you have 5 shots, and 5 shots you get red, green, red, green, red, green. So if you shoot right, it's a 9 means you get green, otherwise you get a red. And there is no point in thinking about this. You can't go back. And after this, the next block comes. After this, the next block comes. And at the end of these 6 blocks, so many people are ousted, and the rest go on. The rest go on. And finally, we have 4 players, and then the bronze medal match, and of course the gold medal match. So it's exactly this way that it's happening, which means how much ever we prepare, more than that, how we execute is the key, and more than that, time is going to be a detrimental factor. So that's the biggest lesson that we have actually learned out of this. And the second most important lesson is, of course, this whole word called integration. So integration in another sense is what is important here. So no question is from a single subject. All these questions are overlapping in terms of the subject. So essentially you need to have good grounding, what we actually call as integration. So if your integration part is very good, then of course you are going to be right in the winner's place. So what is the take home message, if you ask me, in a nutshell? Let me make this very, very clear, and please do take it home as well. It's not an advice, but I think that's essentially the take home message. This is not a surprise package exam. This is exactly like the pattern that we have had before up till 2020. The essential point is, 2 things are very important. One is that the question is going to be a very, very long question. But inside this question, I have to figure out the core. Okay, so the question may have necessary details, unnecessary details, lots of images, etc., etc. But in this given period, I have to figure out the core. And once I know the core of the question, then I have to answer this question. Okay, so to know the core of the question, I need to have good integration skills. And I need to have good presence of mind so that in this short period, I don't get bamboozled by the fear of time, or rather the fact that I have only 42 minutes to solve this block. So my calmness, my composure, how I come to the core of the question, and then how I execute, all these things become very important. So there is absolutely no point in sitting and watching a recall in depth and seeing whether you know this question or not. So when you see through the questions in the recall, please do understand that people are posting the question. Even for this matter, I have tried to post the whole question most of the time, but I think I'm going to be unsuccessful with that because majority of the students don't even remember the whole question. So what we are posting here is the core. So when you read the core, it's actually speaking much more easier. But for the original exam, you have to read the big question, identify the core, and then shoot, which means integration to actually figure out the core, and then your shooting skills. Both are going to come to the fray, which means that you need to really up the bar. And there is even more pressure now because these 40 questions are going to be erased in a matter of 42 minutes, and you're going to have a new block of 40 questions, which means then once your first 40 is poor, then to make a comeback of sorts is going to be very difficult. That's what has exactly happened this time, because when you have a first 40 where you have fared very poorly, knowing that you have answered only 18 questions out of the first 40, when you go into the next 40, this is going to be always there at the back of your mind. Whereas when I was writing writing the exam, I'm having a poor passage, but those questions are not going anywhere. They are right there. So I can always go back and answer them. So even if the first 30 minutes of my exam doesn't really go well, I always have a feeling that yes, there is 3.5 hours. You can come back at any time. Now there is no coming back. It's just like shooting. You have to hit the green. If you miss the green in the first 5 shots, then the comeback is going to be literally very tough. Okay, so what does that actually lead on to? Now this is basically kind of giving us a very important lesson. Like when you see these students who are preparing for the exam, are they preparing under stress? Means yes, they do have stress knowing that the exam is going to come on this date, or the exam is postponed, or I haven't studied kind of stress. But the essential process of preparation is not very stressful. It's a very relaxed mode of preparation, which means either they are reading a note, or either they are very passively looking through what they have actually studied, borrowing somebody else's notes and studying, going through revision content. No, that won't help. You need to develop a proper understanding and study with stress. Study with stress in the sense that you study Addison's disease knowing that a straightforward question on this is very, very unlikely, and I have to catch the angles. For that, integrating it right from the beginning of the topic adrenal and integrating it with whatever possible that is being taught inside adrenal, to know that okay, this is not Cons, this is not Riddles, this is not Cushing's, this is not FIO, this is not APS, and this is Addison, and to know that Addison can come this way, that way. For that, you need to have a structured, systematic mode of preparation, and you need to trust your source more than anything else. That means if you trust me as your teacher, being a clinical person, as the person who probably can help you in integrating, then you have to trust me from head to foot. You have to be watching from the first to the last, the most important part of the videos, and then have essential understanding of the topic, and of course be having your notes. But rather than just going through the notes again and again, the core, whether you have understood or not, I've always kept emphasizing on the core, and this is an exam where it has actually come to big value. So a very relaxed pace of learning where you are actually just seeing through the notes may not actually suffice. So that's the next most important thing that I wanted to actually convey. And this is a question which I wanted to answer. I don't know whether this is the right place to answer that, because of all these things. Is it better to migrate? Let me just try to tell you very simple. Whether it is in India or England, whether the hospital needs you or you need the hospital is the most important part. Whether it's in our country or abroad, if the hospital needs you or the system needs you and you are a sought after person, you can work anywhere. As long as you're not sought after, as long as you have not done anything by merit to actually make you feel good, or to as a force to reckon with, you're not a force to reckon with, it's going to be hard times here or it's going to be hard times there. So it's better to at least be here, so that if you have a degree, then you become more confident, and with that you can always migrate. So essentially, to do a post graduation in India, I feel is mandatory, because that gives you that much needed fillip and much needed respect. And when you go out with that, then at least you are a confident person, you have cleared a tough exam, so that people start recognizing you, or at least people start accepting. So why do I do a recall? So essentially, I am not doing this recall for the candidate to predict the score. That is rubbish for me. Is it for the 2025 aspirants? Yes, but are they going to study these questions and go? Again, not. Is it for me to retrospect my technique? To an extent, yes, because every time the exam is very easy, then I tend to think, should I be teaching so much clinical? Should I be focusing more on integration? So this time, I'm very happy with this. My technique is good, so the integration part is done. Then is it for the 2025 aspirant? Yes, but not in the sense that these PYQs are going to come. Absolutely not. So is it to make my answers clear? Absolutely not. Okay, because these questions, I'm again telling you, are what we got from the student, but this is the core that the student tells you. But there are so many necessary and unnecessary details hidden inside the same question. So because of that, please be very clear that when you read this question, it may be easy, but 40 questions coming as a block at that point to figure out the core and then execute, no, that's what that requires serious skills. So the core of the question you have to figure out inside a minute, and then you need to shoot. So please do understand that the ball game is now changing a lot from the teacher being not as important as the student, because to understand the core of the topic, you can use any source. You can watch my videos, you can watch somebody else's videos, but how you understand it sitting in the exam hall and then how you execute it, it means a large part is with you, and the exam is going to get really stressful. So what has to be done? As we say generally, when the going gets tough, the tough has to get going. How do I get out of this hole? 2-3 things which I can probably tell you. One is not to ever go for any motivation. Motivation in itself is only a myth, okay? You just pull up your socks and you start running. We have to put in the hard work, we have to get up the bar, and we have to be thinking that yes, I will try to somehow come across the bar in whatever way I can. Second thing is, of course, a lot of early bird prices definitely on offer. The earlier you start, the better. You can start as early as you probably can, even your second year, third year, so that you get to used to this learning with a strategy, learning for teaching somebody, learning for clearing an MCQ exam, learning to treat a patient. They're all very different entities. But of course, when you are in a good hospital setting, without your knowledge, you actually learn a lot of things involuntarily. But for a person who is not having exposure to good clinical cases, for him, learning early on will definitely help. And this is essentially what I've been trying to say in all my videos right from the first edition, that if you prepare at a level which is one step above that what is required for the exam, definitely you'll be able to answer a question. If you prepare at a level at which is one step below what is being asked for the exam, you'll not be able to answer a question. But if you prepare at the same level, you are very unlikely to answer because of the heat of the exam, because of the pressure, and because of having to shoot. So to prepare one step above what is required for the exam is imperative to succeed, and that is the core. Okay, so I don't know whether I've actually eaten up a lot of your time who were awaiting a recall and looking for exactly what is the answer. See, if I had written the exam, then probably I could have given you my exact answers. Here it depends a lot on what is the original question, what has been presented to me, the wordings of the question, one point here, there. So the original answer is not at all important. What is important is to understand that the NAT board or AIMS or whoever has taken a leaf out of the books of MRCP USMLE format, making the student learn what is the core, and with that bringing time also into the equation, so that you get the smartest of the smartest, and they essentially are the fittest of the fittest, so that you get better doctors. I think that's what they are essentially trying. So time becomes a huge factor. Learning the core, integrating everything, understanding the concepts properly, and then trying to see how you can actually implement it in a short period of time. Okay, so that is the whole idea. So with that, we'll just try to see through the questions, see whether we have highlighted on the major zones. For somebody watching fresh, this is going to be a utility video primarily because you get an idea. Okay, these are the so-called core areas that they have highlighted with respect to medicine and the allied subjects. So let's start off again with the first session. I may not be exactly right. I try to put it as session 1 and session 2, but there may be few differences here and there. Let's start off with the first session, which definitely was a touch easier than the second session. Though questions are lengthier, the core is much more easier to identify in session 1, whereas in session 2, the questions in itself are a little difficult, and for MBBS student, many times to identify the core may be a touch tough. And this is very useful for somebody who has watched some of our videos to understand, okay, whether watching those kind of content will help you to find the core and shoot. Okay, so let's start off with session 1. So welcome to session 1 questions. So before we set off with session 1 questions, let me just try to once again go a little back and kind of repeat on what I have stressed before the exam. So before the exam, what I have told you is, going by the previous papers, we essentially have the major subjects, the major chapters, I mean, inside medicine, that is endocrinology, nephrology, and hematology. So these are the most high yield 3 chapters from where you get maximum questions. So then you have the moderate yield chapters, which includes CVS and CNS. Okay, then you have rheumat right at the center, because you study rheumat not just to score questions, not just to score from the questions asked on rheumat, but to develop what is called integration, because the most important chapter that you need to study to develop the skill called integration is rheumatology, because all the topics are multi-system, so you understand how to integrate. And then of course the less important chapters, would include gastro and liver, medical gastro liver, respiratory system, and infections, the core infections, I mean microbiology part, of course you have to know. So this is how we actually grade our chapters. This is what I have been telling. Let me see whether my prediction has gone right. So this is what I told you 2023 with respect to the exam, and this is what has been happening. So let's just check on whether our prediction is right or whether the exam did surprise us. The exam did not surprise us with respect to endocrine. We've had enough and more questions on endocrine. Hematology was mighty high yield for this exam, Now what surprised me was nephrology went out of the window this time. Nephrology had hardly 2 or 3 questions here and there. So although nephrology is my specialty and my most loved specialty, unfortunately nephrology came down the radar. So nephrology questions were actually far and few, except for 1 or 2 ABG questions, 1 RTA question was very less. Cardiology in fact went up the bar. They try to escalate. We have large number of questions from cardiology. So cardiology all of a sudden, because that depends on the examiner basically. So every examiner will have his own hot zones, some of the zones which he likes and zone he doesn't like. So it's quite variable that way. CNS also went down. We had hardly 1 or 2 questions on CNS. Gastro and liver as such again was not very important. You have 1 or 2 questions only. Respiratory system also only 2 or 3 questions here and there. Infections also only 2 or 3 questions here and there. So essentially once again this time around it was endocrine hematology, but alongside with endocrine and hematology it was not nephrology. Cardiology of course got like a large share, but that doesn't mean that you can skip these chapters and go. We do get 2-3 questions from each of these chapters, which are very high yield with respect to the final score, because 1 or 2 questions can change your course and your college and your career. So you can't skip these things, but always to know that the core part is these 3 subjects, and studying rheumatology will obviously give you an edge because that will help you integrate with all this. Let's start off with the questions from session 1. First off, a very simple straightforward question, a question on weight loss, tachycardia and heat intolerance and tremor. So of course there is nothing much to think about this. I think everybody would have marked this, but just to get your perspective right, as I have told you on the video, to know that thyrotoxicosis and hyperthyroidism are not one and the same. I think you would remember a student of ours who was holding on to the railing in the bus, I told you, right? So every time he holds on to the railing in the bus, he feels that he is not able to hold on properly. He thought of it as some weakness, then understands that it is kind of a tremor, and then he felt that he is having palpitation and anxiety, and then thought he is having some psychiatric problem probably, and finally he went to the doctor, who asked him about a very important question of whether he is having weight loss and is he taking good food. So he is taking enough food but not able to put on weight, and he was diagnosed with thyrotoxicosis. But thyrotoxicosis is not equal to hyperthyroidism, which we again mentioned, because when you are having excess of thyroid hormones in your body and symptoms because of that, you call it as thyrotoxicosis, which can be due to an overworking gland, okay, which may be exogenous hormones administered from outside, or it may be stored hormones released. So when you are having exogenous hormones administered from outside, that is not equal to hyperthyroidism. Stored hormone release, which is thyroiditis, which is not equal to hyperthyroidism. But when overworking gland is producing these hormones, then it is definitely hyperthyroidism. And overworking gland can be either a solitary adenoma, it can be a multinodular goiter, or it can be something like an autoimmune attack on the gland. And this autoimmune attack on the gland, which is causing the gland to produce a large number of hormones, is called as Graves' disease, and that is basically autoimmune hyperthyroidism. Like your Hashimoto is autoimmune hypothyroidism. This is autoimmune hyperthyroidism. So this is the crux that you need to know to answer this question. But even if you don't know any of this crux, any Tom, Dick and Harry can answer this. But one more question from thyroid, which was asked in the same paper, is a little tricky. This is a question which requires you to go one step above and know ophthalm also. And in the same question, they've asked on increased T3, T4, similar question, decreased TSH. So it's like all hyperthyroidism with this ophthalm appearance, showing that this is ophthalmopathy. So the moment you know it is ophthalmopathy, then you know that it is autoimmune, because multinodular or a toxic nodule will not produce ophthalmopathy. So it is autoimmune. It is Graves' disease. Fine. Now, NOSPEX is a criteria that we use for this condition. Yes, that's a theory question I've mentioned. Everybody has mentioned for Graves' ophthalmopathy, we use NOSPEX. And this is the slide that I always teach with respect to the treatment. I don't go into the details generally because it's for the ophthalmologist, but we generally kind of try and wait and watch for mild cases. We give steroids generally to prevent progression. And if at all there is a poor response in 2 weeks to steroids, then we always go for prompt decompression. There is always a chance that there can be an involvement of the optic nerve and you can lose vision. So all those things we have seen, and there are hundreds and hundreds of signs, important signs we have actually discussed and all that. So severe disease can cause visual loss. This is also easy. So these two options are pretty much done. It's of course a confusion between these two statements. I'm not sure whether exactly this is the same statement asked for the exam. In 10% of the condition it presents without hyperthyroidism. So that's something which I think we've been taught from MBBS times. Graves' ophthalmopathy 90% of the time has hyper, 10% of the time maybe euthyroid or hypothyroid, and majority of the cases maybe euthyroid inside that. Some of them may be hypothyroid also, rarely. So it's 90%, which I think is a fact-based point which everybody has discussed. Now, even if you don't know that, the condition will improve simultaneously with improvement of thyrotoxic state. Now, that is a rubbish option, because we have discussed the treatment of both are completely different. The treatment of toxicosis is all to do with your methimazole, carbimazole, beta blockers. The treatment of this is wait and watch or go for steroids. If steroids not working, go for decompression. It's a completely different thing. The more you treat toxicosis, is ophthalmopathy going to improve? Means that's just a common sense question. Somebody who has just about seen 1 or 2 patients with this will be able to answer. That's the other big advantage. That's a big a reminder for the repeaters, because how much ever you try hard, if the person is well oriented from MBBS, is doing his internship properly, is going for his final year classes properly, is studying in a proper college and watching videos from 4th year, it is impossible to beat him. How many times you repeat? That's a simple reason why statistically people who repeat time and again time and again actually come down with respect to the ranks, primarily because you are always giving your first chance, or now we used to consider the second chance as the best chance. Now I say your first chance is your best chance. So that's it. So that's why this is the wrong statement for this question. I don't think it's a tough question. Many people think it's a slightly tougher side question. No, absolutely not. If you have watched the content and studied, then of course you'll be able to answer that. But even if you have not watched, use a bit of common sense, I think should be able to get through. Okay, so that's it, and always look out for this. These are my slides. Just look out for when you suspect. That's why you can get a clinical question on any of these grounds. Weight loss in spite of increased appetite, hyperactivity, nervousness, tremulousness, somebody coming with a periodic pulsic hypokalemia type, fibrillation in the elderly, worsening of heart failure in the elderly, depression, proximal myopathy, fatigue and weight loss in the elderly, which what we call as apathetic thyroidoxicose. So these are all the grounds where you can actually suspect Graves, and different scenarios with respect to Graves we have discussed. Okay, so let's go to question number 2. So EC fatigability, anemia, hyperpigmentation, oral mucosa, palm and tachycardia, BP 80-60, sodium 130, and in that question I think potassium was on the higher side, I think 5.6 or something. What is the most likely diagnosis? The most easiest question that you can actually ever expect. So whenever you are having EC fatigability and you are having hypertension, of course the most important differential that has to come to your mind is a adrenal insufficiency. Adrenal insufficiency is what we actually call as Addison's disease. Addison's disease can be due to a problem in the adrenal where it is called primary adrenal insufficiency. It can be due to a problem in the pituitary, what is called secondary adrenal insufficiency. If it is a primary adrenal insufficiency, then automatically you'll be having glucocorticoid, mineralocorticoid and sex steroid low. Of course, when mineralocorticoids are low, you can have some hyponatremia and hyperkalemia, and of course ACTH will be high. So ACTH high will lead to hyperpigmentation of the mucosa, palmar crease, knuckles, anywhere. So basically it's ACTH high, so it's a primary adrenal insufficiency. It's very simple. Conn syndrome is not going to have hypo, it's hypertension. Cushing syndrome again is going to have hypertension. Vitamin B12 deficiency has got nothing to do with this, although hyperpigmentation can be a feature of vitamin B12 deficiency, but to have a patient with hypotension, hyponatremia, hyperkalemia and EC fatigability of course is not the case. And I've told you that anytime any patient has unexplained weight loss and EC fatigability, just like you think of your leukemias, your lymphomas, your malignancies, your TB, your HIV, something from endocrine that has to present similarly is always a Addison. So these are all the things that we have discussed. Also we have discussed about Addisonian crisis, how a patient comes with that, how to manage that, all that we've discussed in detail. So just a preliminary question, you can come to the core of this question in hardly 10 seconds and shoot the question in the next 5 seconds and probably go on to the next one. Okay, so this is the second question from here. A patient presents with perioral pigmentation, same question, what is the most appropriate treatment? So this is basically what they've tried to ask. So anybody who comes with Addison, essentially the most appropriate treatment is to replace hydrocortisone and then to add a small dose of fludrocortisone depending on hyponatremia, hyperkalemia. So here you can actually add a small dose of fludrocortisone. So hydrocortisone plus fludrocortisone. Somebody was asking me, is sodium chloride infusion the answer to this question? Absolutely not. Sodium chloride infusion is the mainstay of treatment for a patient who comes with something called as Addisonian crisis. And Addisonian crisis, the patient will be having frank circulatory failure, frank shock, circulatory collapse, abdominal pain, vomiting, all those things. This is basically not Addisonian crisis. Addisonian crisis patient also giving steroid and giving fluids, both are equally important, but they are also most life-saving if you ask me, is definitely giving steroid, but it's pretty debatable. In this question, there is no question, there is absolutely no confusion. You are going to give the patient steroids, and hydrocortisone with fludrocortisone is treatment. You can go back and see how we give this, what dose we give this. I've gone to the extent of telling you how to titrate the dose, what dose to start off with, and then go to oral hydrocortisone, how to give oral hydrocortisone 10, 5, 5 depending on the circadian and all that. So that's very important, because you go one step above the bar and study, this kind of a question becomes easy for us. Which of the following is correct about pheochromocytoma? This is a very easy question, because 90% bilateral, 90% extradental, 90% malignant is all wrong. We have all studied the rule of 10, and I told you how rule of 10 has gone out of the window, and now it's a different kind of a thing. Almost 25% are extradental, almost 50% are malignant, about 25% are 10 to 20% are actually speaking bilateral. So all that we have discussed. So 90% is definitely wrong. And men 2A components, and I've told you how important men is as such as a topic. So in men 2A you have medullary carcinoma thyroid, you are having pheochromocytoma, you are having parathyroid involvement. So all that we have discussed. So this is a pretty easy question. Okay, so how quickly you come to the answer is the point, so that you can actually devote the time for something else. Now, this is a tough question. a tough question, because unless and until you have studied the theory part of it, you can't answer. But these kind of questions are similar for everyone. I don't think anybody would have answered this confidently. So, but we have taught this in class, but whether you remember or recollect it properly and write, nobody can do anything. So, what is stage 3 beta cell damage in type 1 diabetes? This is the slide that I have actually taught you. You can see here, stage 1 is autoimmunity but normoglycemia. Stage 2 is autoimmune pre-symptomatic but dysglycemia. Stage 3 is autoimmune, dysglycemia and symptomatic. So what is stage 3 is that it is symptomatic. That is the only difference. So autoimmune normoglycemia pre-symptomatic stage 1, autoimmune dysglycemia pre-symptomatic stage 2, autoimmune dysglycemia symptomatic stage 3. So here they have not gone for the symptomatic option, so it is autoimmune and dysglycemia. If this is the right question, this is a tough question. Unlike the other questions that we have discussed so far, we cannot use any kind of common sense to answer this. Whether we know, if we know, we know, that's it. But if you watched a video and made notice of this, this is our own slide and the same diagram you can see in your notes as well. If you've studied that specifically, then you can, but I am not somebody to tell you that you should have studied this specifically, because the simple reason that I never stressed on stages, because I never told you that okay, stages you have to be very clear with, because it's unlikely to get a question like that, but this is part of the game. Now this is a question which was asked from liver, in fact the only question from liver, on what is the best investigation for Wilson. The gold standard for Wilson we have discussed in great detail to show you that no single test is specific for Wilson. There are a lot of problems in serum ceruloplasmin where you get falsely low, falsely high, etc. And this is my own statement that the biopsy must be 1 centimeter in length and parenchymal copper concentration has to be measured this way. The gold standard is a hepatic copper concentration estimation either by neutron activation analysis or atomic absorption spectrometry from a liver biopsy. This is the gold standard, and all the other tests are basically just aiding you. And what is the importance of each test, how we start, how we look into each one of this, we've had a detailed discussion on that. So that's why I'm trying to tell you, first you fix on your source. If you fix on your source and then you have trust in that person, then automatically you will develop a liking towards that person. And then if you follow him from head to foot, automatically at some point in time he would have discussed these things, and once you study the modules in order, things will start hitting. So first and foremost, you see whether you're able to like that pattern of narration. My pattern of narration is something which some students may like in a big way, which may not be acceptable for somebody else. So you first see whether this pattern of narration is good, because I'm not a very structured, systematic teacher. I'm more of a clinical person. So I don't exactly know how to teach like how a normal teacher would do. So my class would would be always having its own share of what is a surprises, in the sense that it is a clinical kind of a game. So some things which are expected, some things which are not expected, etc., etc. If you're used to that kind of a narration, because for me in a hospital setting there is nothing called ordered and systematic. For the exam also there is nothing called ordered and systematic. So what's the point in studying very ordered and systematic? No. So we need to be able to integrate, go from here, there, correlate, integrate. So that's exactly the pattern. So if you're able to understand that pattern, fall in sync with that pattern, just go full on. If you're not, then you go for another source where the teaching is in concurrence or in sync with the way that you want to learn. So I can only teach you the way I think is the right way to learn, which means that disordered pattern is probably the best way to learn. But as far as edition 8 videos are concerned, we have not gone that way too much. We have actually gone in sync with how a normal student would be able to study in a specific period of time. Edition 6 videos, 6.5 videos are the ones where you can actually go for a very wide based learning, where time is not a constraint. In edition 8 videos, we have made a conscious effort to see to it that these videos are going to be completed within this stipulated period of time. So that's what makes it more point centric. The other one is more non-time frame based. Okay, then mother brought a 2-year-old child to the OPD with complaints of lack of weight gain, abdominal pain, poor eating habits. So here gluten-free diet is there, so you can very easily write it as celiac. But otherwise also, please keep in mind atypical celiac disease. I've told you celiac is the disease for generations. Short stage of failure to thrive, anemia, workup, osteopenia, ataxia, peripheral neuropathy, raised LFT, and osteoporosis. So all these things are very important. If you see a patient at any point in time with these things, please think of celiac. I told you what is typical celiac, presenting with malabsorption, atypical celiac coming with signs and symptoms other than malabsorption, latent celiac, and all these things we have actually seen. Okay. So diagnosis, you have IgA TTG as the single most useful test. This was another MCQ question, so I didn't bring the options otherwise. Single most useful test. We've discussed about endomysial, TTG, anti-deaminated glutamine dipeptide, what to use where, what sensitivity, specificity, etc., etc. From GIT, we had another question on acanthocytes. This is again something that I discussed. Acanthocytes with neurological symptoms and steatorrhea due to this microsomal triglyceride transfer protein deficiency is what we actually call as A-beta lipoproteinemia. I've also discussed about A-beta lipoproteinemia along alongside Whipple's and a gamma globulinemia, because these are three conditions which you can actually diagnose on a biopsy. So this is another question. Okay. And then comes the world of hemato, because hematology have had so many questions. So please follow path videos and medicine videos. In medicine, we've done the entire path part also. If you watch both, best, if not at least one, very thoroughly. So this is a question on CD markers. We've done a specific session on CD markers and how to identify that. So CD10 you know, and CD19 you know, CD20 here, I don't know whether this is the exact question. CD3 negative is just to tell you that the patient is not having something like a T cell lymphoma. CD5 negative is actually speaking given to tell you that it is not a mantle zone lymphoma. TDT negative is given to tell you that this is not ALL. So this is this DLBCL or is it Burkitt? Now actually speaking, DLBCL and Burkitt both coming from the germinal center. You have a germinal center DLBCL, you also have a ABC DLBCL, but either case the most important one is germinal center. So Burkitt is also coming from the germinal center, DLBCL is also coming from the germinal center. So essentially to differentiate between these two based on these many parameters is not possible. Just because they gain it as a 12-year-old boy with cervical lymphadenopathy, I would probably mark it as Burkitt. But anyone marking DLBCL also is definitely not wrong. But to get DLBCL at 12 years of age is near to impossible. The average age is 60 years. So which means that it's slightly in favor of Burkitt. But remember that since both of them are arising from the germinal center, it is absolutely not possible to figure out with the help of these markers. Although there are certain other things like BCL6, BCL2 which we have discussed, but those are not given in the question. So from whatever data is given, it's likely to be Burkitt. Even if you don't know this and you know that Burkitt is more common in a child, many people would have marked it that way. But knowing the CD markers, knowing immunophenotyping is very important, and we have actually done specific sessions for that right from the beginning, how you actually chart out logically. Yes. Then comes this question on von Willebrand disease, a very straightforward question. Von Willebrand disease type 1 is the most severe, no, type 3 is the most severe, whether it's complete absence. Von Willebrand disease type 3 has severely low levels of von Willebrand factor, in fact it has 0 levels. Type 3 is the most severe disease in this case, that is also correct. Type 2 is associated with bleeding, and there are so many types of type 2, I've gone to the extent of teaching you 2A, B, all those things, right, M, N and all that. So most severe disease in children is not 1, it is 3. Those 3 is very rare. It's a very simple, straightforward question on von Willebrand disease. Now this is a very straightforward question, though framed clinically. So it's like platelet count of 25,000 anytime having low platelets. First thing to come to mind is of course acute leukemia. With low hemoglobin means then the suspicion is much more higher. So you're thinking in terms of acute leukemia. What type of acute leukemia? We have no picture, but suddenly they've given it as raised PT and APTT, which is standing for DIC, and DIC is seen where? It is seen in APML, and what do you see in APML? It is PML. Okay, so it's like that's how you come to the answer, right? So everything has a route map. Every route map we have discussed. The more times you watch the video, the route map hits on your head. Even if you watch the video less hours, if you're seeing going to the hospital, then that will hit you. So just think of where you stand. If you're a person not getting enough clinics, watch the videos repeatedly to get a solid understanding. If you're a person going to the clinics, watch it once and then go to your wards to get a solid understanding. This is abdominal pain, probably due to the big spleen, hepatosplenomegaly with leukocytosis, most likely involved in this is 922, which doesn't require any major degrees of understanding. So this is what has been asked from the hematology side. Most of the questions are actually speaking easy. For the questions that I've discussed, so far, I personally feel this is the only one real tough question. This is a tough question because your stage 3 beta cell is something which is tough to answer. Between Burkitt and DLBCL, the markers are not able to helping you to differentiate. So probably age is the only thing that is helping you. This is the question on ABG, which is a very easy question. 7.3, bicarb 6.3, PCO2 16. So which means that we are having acidosis here. We are having metabolic acidosis here. Bicarb, let's take it as 6, so it is gone down by 18. So 18 into 1.2 is the expected compensation, which is almost a 21.6 compensation. So here actually speaking, metabolic acidosis is compensated, but then they have not given such an option. And you calculate the anion gap, which is 135 minus 113 plus 6, which is of course more than 12. So it's a high anion gap. So metabolic acidosis with partially compensated respiratory alkalosis with normal anion gap is wrong. Metabolic acidosis with partially compensated respiratory alkalosis with a high anion gap. Actually, the answer is wrong. Metabolic acidosis with the respiratory alkalosis or compensated metabolic acidosis with the high anion gap is the correct answer. But anyway, they have not given the fully compensated one anywhere. Probably what the examiner wants to tell you is that even though all this compensation has happened, pH is only 7.3. It has not come back to 7.4. So he doesn't want to call it as a fully compensated. There are some teachers who think that way. That probably may be the reason why he has given it as partially compensated. So anyway, this is the answer. So again, nothing much confusing over there. Emergency department dyspnea palpitation. Just to tell you that this time you got an easy question on this, but don't take it easy. Next time it may be a tough question, maybe hypokalemia, hypercalcemia, hypocalcemia. So know all the findings, know how to find out those ECGs. Look out for the catch findings as soon as you get a ECG. Hypercalcemia in a CKD patient is a very rare proposition, so don't have to know that. But short QT is the catch point, but the question will not be on CKD. Hypocalcemia is very likely with CKD. Torsade pointus is also there, so look out for long QT intervals, very important catch finding. Hypokalemia can have different manifestations. Look out for the ST, look out for the U wave and all that which we have discussed. And hyperkalemia, be very thorough with respect to each and every point in hyperkalemia, because that is the true hero as far as the CKD is concerned. Although I consider phosphorus as the hero, but in an emergency, potassium is the hero. Medium vessel and small vessel pauci-immune, when you hear the word itself, you know that it is ANCA vasculitis. So in this particular question, they had actually given pulmonary hemorrhage also. So you can get ANCA vasculitis pauci-immune in two conditions, microscopic polyangiitis and Church-Strauss syndrome, what we call as EGPA. But pulmonary hemorrhage was given in the question, and pulmonary hemorrhage is something that you associate with microscopic polyangiitis. Fleeting infiltrates is what you see with Church-Strauss. So that's why the answer to this question is microscopic polyangiitis. Although Church-Strauss also can have the same pathology, but again it's very important to know that Church-Strauss doesn't cause severe RPG, and Church-Strauss doesn't cause severe DH. Church-Strauss doesn't cause anything like nodules in the lungs. So nodules in the lung should make you think of Wegener. No nodules, no URI upper respiratory manifestations, but proper DH should make you think of microscopic polyangiitis. Fleeting infiltrates, atopic dermatitis, atopic rhinitis, allergic symptoms, asthma-like symptoms and all should make you think of EGPA or eosinophilic granulomatous polyangiitis, what we call a Church-Strauss. 56-year-old male, fever, cough, BP slightly on the higher side, respiratory rate, SpO2 88%, X-ray showing a cut and clear consolidation. It's a very clear case of community acquired pneumonia. Just trying to check out whether you know how to diagnose a pneumonia, which of course is part and parcel of our work. So you don't not studied anything from the video also, should be able to get on with this question. There was a question on cartaginous syndrome, okay, with dextrocardia, that is situs inversus, chronic sinusitis, bronchiectasis and male infertility, which is also a very easy pick. That's what I'm trying to tell you. Respiratory system is less important. One, because respiratory system questions are less in number. Second, because the questions asked from respiratory system are also generally very easy. Dyspnea, chest pain, this is trying to test out one important point. So all the students do know that there is Light's criteria, exudative effusion is there, transudative effusion is there, and they know the important causes for exudative and transudative. But you should be knowing this. Only if all the three are not satisfied, we call it transudative, which you have highlighted very important. So here one is satisfied, which means that this is exudate, and exudate here is only TB. And I told you that there are so many causes for exudate that is not possible to remember. At least remember the transudative cause. Congestive cardiac failure, cirrhosis, nephrotic syndrome, everybody knows. So please remember myxedema, please remember superior vena cava obstruction, please remember patient on peritoneal dialysis, please remember urinothorax, please remember Budd-Chiari, constrictive pericarditis, hypoalbuminemia. All these things are causes for transudative. Everything else is exudative, and it's very common to get a question on pleural effusion. You would have presented it for your final year exam also. So please be very clear with this. We are generally going in a very fast pace here because it's not a video to teach you. Even the videos that are meant to be taught are actually going at a fast pace because the exam is at a fast pace and shooting is always at a fast pace. Okay, all these things. Then bronchial asthma patient. This is a long stem again. If you understand the core, then it is so easy. What has Gina told us? Gina has told us that there is no point in giving these bronchodilators in a patient with asthma. Asthma is all about inflammation. So the mainstay of treating asthma is always giving steroid, and that is inhaled steroid. So the answer is that fluticasone. You don't have to know anything. This is the Gina statement. Gina does no longer recommend short-acting beta agonist alone. Instead, all patients should receive inhaled corticosteroids. All patients should receive inhaled corticosteroids. That is the essential core of GINA, and that's what we have discussed in our edition 6.5 as well as 8. Edition 6.5 we've gone for the 2022 GINA guidelines, and this edition 8 we've gone for the 2023-24 GINA guidelines, where we have mentioned very clearly as to what are the changes from the old pattern treatment for asthma, and gold COPD, what are the changes from the old pattern treatment for COPD. Okay, COPD, ARDS, what is the role of interleukin 8 in inflammation? Told us so many number of times. Interleukin 1, TNF alpha producing fever, interleukin 6 for the vasodilation part, interleukin 8 is more of a chemotactic agent which recruits neutrophils. So simple pathology question, but again lot to do with medicine also. Then pan-acinar emphysema, I don't think anybody has any doubt. Alpha-1 antitrypsin, again pathology come medicine question. Asbestos bodies, ferruginous bodies, all those things I have shown you. So again, this is going to be pretty straightforward. See, so although the paper is looking, a paper from the outside people are saying is tough, tough, tough. When we individually scan through the questions, what is that you are able to understand? All the questions are not tough. They are easy, they are moderate, they are slightly tough. But the fact is that whether we are able to identify the core of the question, I am showing you the core only because I don't have the exact question, full length I don't have. There are students who have told me that the question is filling up the screen, which means from that to read in such a quick period of time, figure out the core is essentially the most important part as far as success is concerned. So with that, we go to the cardiology side for session 1. So first, a pharmacology question. Beta blockers for reducing mortality in patients with heart failure is something which keeps on getting repeated again and again. What are the fantastic four? Please be very clear with the fantastic four. Inside fantastic four, the one that has maximum benefit with respect to mortality is beta blockers. What are the beta blockers approved? Metoprolol, bisoprolol, carvedilol. We've been highlighting this time and again. So here the answer is bisoprolol. Second one is a question on pulmonary artery hypertension. So you know scleroderma is there. Scleroderma's major complication, here it is a limited scleroderma where the major complication is pulmonary artery hypertension. What could be the treatment of a pulmonary artery hypertension? What we start in all patients is bosentan tadalafil combination, which we have discussed in detail, and when to start CCBs depending upon this vasoreactive test and all we have seen. So here bosentan tadalafil combination is not given, they just given endothelin receptor blocker, which is bosentan. So that's the answer. Okay, so that is like, see, question is from a module. There is a module on PH, there is a module on scleroderma, whichever one, or there is a module on heart failure. Whether you understand the crux of that module and whether you are able to reproduce it for the exam. So if you're not seeing patients, then watch the module repeatedly, go through your notes repeatedly, add on to whatever notes that you have purchased, and develop a proper understanding so that when you get it as a question for the exam, you are able to answer. Don't expect one-liner questions like what is the drug of choice, what is the treatment, etc. You're not going to get questions that way. Every question is going to be a little twisted so that your proper understanding has to come and identify the core and then shoot. Okay. 50-year-old female presented with pedal edema, angina and all that. What would you consider as aortic stenosis over aortic regurgitation? So this is basically the first module in cardiology that we discussed tons and tons about aortic stenosis and regurgitation, to the extent that people have asked me, why do we need to study so much about aortic stenosis? This is the reason. Aortic stenosis is the one that we have used as the benchmark to compare with the other diseases. So how is it different? It's very simple. Pressure hypertrophy is what we see in aortic stenosis, and this pressure hypertrophy comes at the expense of the cavity size, and you have eccentric hypertrophy with dilatation in AR. So eccentric hypertrophy with dilatation in AR, pressure hypertrophy with reduction in cavity size in AS, which means pressure hypertrophy is LVH, and LVH will lead to increased oxygen consumption. That is one among the important reasons for angina in AS. If you look through our discussion of AS, on AS you will understand that we have highlighted on angina, syncope, dyspnea, 5, 3, 2, and the risk for sudden cardiac death also. So angina is the first symptom in AS, and I have asked you this question, do we get angina in AR? Very unlikely, except for nocturnal angina that you might get. Do you get angina in MS? No. Do you get angina in MR? No. Why do you get angina in AS? Then there are set pattern things. No. The first thing mentioned is LVH. Because of LVH, you are basically having increased oxygen consumption. So increase in myocardial oxygen consumption is the important answer. Reduced pressure of the aortic valve? No, basically nothing like that. We don't use such, we always use the word gradient, right? It is the iota versus the LV gradient, LV iota gradient, LV iota gradient. Workload has nothing to do with oxygen consumption, definitely wrong. Increase in preload causes more reduction in myocardial oxygen demand? No, definitely increase in preload causes more oxygen demand, naturally. That's why we try to reduce preload with nitrates in a patient who is having chest pain, because your angina is directly proportional to the oxygen demand, is directly proportional to the volume of blood coming in, that is directly proportional to the preload. This is your myocardial myofiber disarray, what we actually call in HCM. Another question on HCM was also there, which is on Valsalva, which we will come to. Then 4 ECGs were given. I'm not wasting time on showing you the ECGs, but I think all of you have got this question right. SVT, AFib, atrial flutter, and also VT. So naturally, a very simple roadmap you have: narrow complex tachycardia, wide QRS complex tachycardia. Wide QRS complex tachycardia is almost always VT at your level, although SVT with aberrancy can also be there, but mostly it is VT at your level. Narrow QRS complex tachycardia, whether P wave is there or not there. If P wave is absent, then you look for whether it is like a regular, irregular. Irregular is AFib, and sawtooth pattern you can actually see with flutter. And if you are having regular QRS complexes, 2/3 of the time AVNRT can come like that, although 1/3 of the time P wave may be seen outside the QRS complex, like a pseudo Q, pseudo S, etc. all that. So this is a basic ECG thing. ECGs and all, even if you have not watched the video, if you are studying somewhere, we have seen the ECGs, this is easy. Yes, this is another question where a lot of details are there, but if you pick up this one detail, rapid wide descent, you can mark it as chronic constrictive pericarditis. You don't have to know anything more. But the message is very clear. What did I tell you? I've told you about a patient whom we admitted under gastro, thought that the patient is having liver disease with abdominal distension, with ascites, with pedal edema, hepatomegaly and all that. And then our chief said, you look at the JVP, transfer the patient to cardiology, because every time we can wrongly diagnose a CCP patient as a chronic liver disease patient. So that's why it's extremely important to look for the JVP, and JVP you may not identify this descent, wide descent clinically, but at least if JVP is elevated in a patient who is having a liver issue, not liver issue per se, looking like a liver issue, always think of chronic constrictive pericarditis, which I have actually highlighted and highlighted and highlighted so many number of times. That's exactly what has come for the exam also. This is the same ECG, hyperkalemia ECG. So these are the questions that we could actually collect from session 1, trying to again give us the idea that session 1 was on the easier side. If you look at a tough question from here, I would say the only tough question is stage 3. Stage 3 of beta cell destruction in a type 1 diabetes patient. Apart from that, none of the questions are tough. But does that mean that everybody would have answered this? No. Why? Because their understanding is not good enough. So you improve on your understanding. How can I improve on my understanding? One, going to the clinics. If you are in that position, please do that. If you're not in that position, watch the videos, which are core clinical videos with clinical integration. You can see some clinical integration videos that we have done last year, which are put on YouTube when Next was announced suddenly in 2023, and we just did like two videos. I think each video more than an hour or something, and you can just watch that to see how clinical integration questions can come, how MRCP pattern questions can come, and how we tackle those. Let's go to session 2, once again starting off with endocrine. So a clear case of acromegaly is given. What is true is the question that is being asked. So acromegaly, this is what we have studied. IGF-1 age-based is the screening test. Failure of suppression of growth hormone to less than 1 nanogram per ml after 75 gram of oral glucose load is the confirmatory test, and gadolinium enhanced MRI is the investigation of choice. Everybody knows this. Let's go back to the options. Growth hormone levels less than 0.4 is, I don't know what is the exact value. The exact value is less than, failure of suppression to less than 1 nanogram per ml, because if it is normal, it will be suppressed to less than 1 nanogram per ml. If it is acromegaly, it will be more than 1 nanogram per ml. So anyway, that is wrong. IGF-1 is useful for screening, correct. Single early morning fasting level of GH, absolutely no value. GH levels are used to assess the severity of condition. No, we don't do that. But there is one statement, be sure. GH values more than 40 nanogram per ml indicate poor prognosis. That's correct. So that's why you can't strike it off completely, but this is a much more better statement. GH is not used to assess severity, but if it is very high, then you can probably say that it is having a poor prognosis. That's all. Okay, can't use it as a reliable indicator. So very simple. IGF-1 is a screening test which we have discussed 1000 number of times, and failure of growth hormone suppression after glucose loading, and that is called glucose induced growth hormone suppression test, and we have discussed that. So slightly on the higher side, but if you've studied properly the topic, you should be able to answer. That's the difference between paper 1 and paper 2. Paper 1 morning session did not require you to go so much in depth into the topic, but here you have to go properly in depth into the topic. 40-year-old female patient, non-case of myasthenia, on so many drugs, coming with a hypercalcemia. So hypercalcemia 13.5 is seen in which all conditions? Of course, parathormone related it can be, PTH-RP related it can be, which is mostly a squamous cell carcinoma, or it can be something like a sarcoidosis. All these things are possible, right? Adenocarcinoma of the lung and small cell carcinoma of the lung, definitely no. If it is squamous cell carcinoma, I would have considered. But this patient is already having a myasthenia, autoimmune condition, very likely to have a parathyroid adenoma, another autoimmune condition. 80% of cases of hypercalcemia are because of parathyroid related, and in that the most important cause is parathyroid adenoma. Female patient also parathyroid adenoma, 40-50 years again thinking in terms of parathyroid adenoma. So why can't it be parathyroid adenoma? It can be parathyroid adenoma. Okay, drug induced, no drug is mentioned. MMF and pyridoxine don't produce hypercalcemia. Squamous cell carcinoma you can think, but that is not there in the option. If it were there in the option also, then something maybe you would have thought that way. But most common cause logic is PTH adenoma. So these are the kind of questions nobody can teach you, but if you have the basic grounding, in a matter of 10 seconds you can answer that. Okay, this is to tell you the majority of the causes. 2-year-old child is brought with difficulty in walking, calcium parathormone levels normal, alkaline phosphatase high and phosphorus levels low. This I think they were trying to look for hypophosphatemic rickets. I think it's a very straightforward question, because we have the vitamin D dependent rickets, vitamin D dependent rickets type 1, type 2. In either case, PTH would be high and calcium would be on low normal side and phosphorus would be on the normal side to the higher side. When you're having everything else normal, alkaline phosphatase alone high and phosphorus low, then you're losing phosphorus. That is hypophosphatemic rickets, which is most often due to X-linked hypophosphatemic hypophosphatemic rickets, which is due to FEX gene mutation, and that is characterized by lower limb abnormalities, which are more obvious when the child starts to walk. So everything is pretty much in favor of a hypophosphatemic rickets, which is your X-linked hypophosphatemic rickets. I have gone to the extent of teaching about DMP1, FGF23, the dorsal dominant part, the recessive part, etc. All that is not required here, just to know it is X-linked. Okay. Then comes a 10-year-old boy with visual disturbances and headache, found to have a suprasellar lesion, and biopsy exclude black motor oil-like fluid. Even that is good enough to answer it as craniopharyngioma. Okay, craniopharyngioma comes with this dirty appearance, right? Black motor oil-like fluid and suprasellar location. Suprasellar mass and how to differentiate and all that we have seen. One question from liver here, that is jaundice raised HbS-Ag 1 year back. On follow-up now, normal levels of liver enzymes. Current profile is shown in the image. I'm not exactly sure what is the image. 1 year ago, you have a hepatitis B with jaundice. That is mostly acute hepatitis B. In acute hepatitis B, 95 to 99% people have actually recovered. Only 1 to 5% of people will go for chronicity. People who have recovered will have only anti-HBS. They are not going to have anything else. People who have actually gone into chronicity will be having anti-HBC IgG, and they will be continuing to express HbS-Ag. In this particular question, I think they have said nothing is there, everything is normal. So probably current condition is a resolved infection is the best answer, I feel, depending on what is given. So you know the table, you've taught the table, I've taught the table in detail. Depending on what is given, you please answer. But the core concept is the same. Jaundice with raised liver enzymes and symptoms, etc., means the patient has had acute hepatitis B 1 year ago, of which the majority people resolve. So that's, I think, what they want to test. Then flank pain, hematuria and all that for renal cell carcinoma, family history of brain tumor, kidney tumor, all that is pointing to VHL. So very simple, straightforward thing. We've discussed it under the Meon syndromes. So you have now not just Venn syndromes, Meon syndromes. In Meon syndromes, we have hyperparathyroid jaw tumor syndrome, McEwen-Albright syndrome, we have von Hippel-Lindau. So that's what we have discussed there. Now, 38-year-old woman comes with a complaint of weakness, lethargy, heavy menstrual bleeding, small RBCs, pallor. Hemoglobin is 9, MCV is low, TIBC is high. Very straightforward question with respect to iron. Iron, everything you have to be knowing, okay? All the points about iron metabolism, everything with respect to iron profile and how to figure out and to differentiate with sideroblastic and thalassemia minor, and also with anemia of chronic disease. Fatigue, weight loss, polyuria. This is another tough question. Again, I am not able to figure out what exactly is the question. Some people say that a plasma cell was asked. So if a plasma cell is given in your picture and you are having all these things with the polyuria, which can be because of a tubulointerstitial involvement, you probably can say it is a multiple myeloma. But then age is not there, nothing else is there. Some people think it is a subacute combined degeneration due to cobalamin deficiency. In that case, you should be given megaloblasts in the picture. If megaloblasts are given in the picture, fatigue and tingling sensation is correct. Weight loss is not too much of a point, but in case the megaloblastic anemia is because of a pernicious, you can have that. And history of polyuria, again because of some spinal cord involvement, unlikely to get polyuria, but depends on the original image. We don't know what is the original image, so I can't comment on this. I am not in favor of commenting on this. Another thing you can think of is that the patient is not having either of the two, and the patient is having only a diabetes and a simple diabetic neuropathy, because of which he has tingling sensation, because of which has fatigue, because of which has weight loss, and because of which has polyuria, and the bone marrow biopsy is not showing anything like a plasma cell. That way, if you think, you can think that the patient has diabetes, and because of diabetes, all these things. Subacute degeneration due to diabetes is basically not described anywhere. So because of that, this becomes a real tough question. I can answer this question if you give me the exact options. If the exact options are fitting, then fine. One way they can think is that you are having a cord involvement because of multiple myeloma. Multiple myeloma is responsible for the cord symptoms. Multiple myeloma is responsible for kidney involvement and polyuria. Multiple myeloma is causing your peripheral smear to have a bone marrow to have plasma cells. That way it's right, if provided you are having plasma cells here. Second is that you can think it is a B12 deficiency which can cause these spinal cord symptoms, but B12 deficiency, weight loss, polyuria are very unlikely. So because of which I would put it down the list. Safest way to think is that everything is because of diabetes, and diabetes is actually responsible for the whole picture. But then does diabetes have something like a cell on the smear? No, you don't have. So that way it becomes a problem. So depending on the exact question you have to go by. From my gut feeling, if they have asked something like this, then they have put a plasma cell, and they have put a plasma cell to maybe make you think in terms of multiple myeloma is what I feel, but definitely the answer might change depending on the original question. Okay, P1L1 microcytic hypochromic anemia, serum iron was low, and increased RDW. So everything like iron deficiency anemia, transferrin saturation, serum transferrin saturation, what will happen? Transferrin saturation is actually speaking reduced, you know, right? So percentage saturation of transferrin is equal to serum iron divided by TIBC into 100, and if serum iron is low and TIBC is high, this is going to be on the lower side. Again, that's what I'm saying, simple questions with respect to iron. Then unintentional weight loss, enlarged cervical nodes, and they've shown a very clear Reed-Sternberg cell, and you know we have discussed the treatment of Hodgkin in detail, and what we are giving is the ABVD regime, and we have discussed about ABVD, how ABVD has evolved over time, how many cycles of ABVD you require for lymphocyte predominant, whether you give radiotherapy or not, and in this ABVD, how now brentuximab is coming into the picture and making things much more better for Hodgkin's patients, and how to escalate to BIACOP regime and all if it is not responding. I have gone to that extent and not if you simply know ABVD, that's more than enough. Okay, adriamycin, bleomycin, vincristine, and your dacarbazine. So that is basically your ABVD regime, and that's what has changed the landscape of Hodgkin and improved survival so much. 53-year-old patient came with fatigue, icterus, anasarca, anemia, neutropenia, plasma cell, and they've asked to identify something. Most of the people say that it was a amyloid deposit that they wanted to identify. None of the other things are matching, so probably they want you to identify amyloid. This is very simple, serum immunoelectrophoresis. I have shown you and told you how to study to interpret immunoelectrophoresis. You need to have one band right here. So I think the band was in IgM and kappa. See for whether the band is safe, because the whole point is about monoclonality. What is the meaning of monoclonality? Light chain restrictions. All the immunoglobulins are either kappa or lambda. So you have a kappa or a lambda myeloma. Inside that, if it is IgG, then IgG kappa, or IgM and IgM kappa. Most commonest type will be IgG kappa. So you get a band at IgG, band at kappa. This is called SIFE, serum immunoelectrophoresis. To diagnose myeloma, we require serum protein electrophoresis, serum immunoelectrophoresis, and serum free light chain assay. Serum protein electrophoresis will give you the M band, just to tell you that gamma globulins are high, and there is a monoclonal gammopathy. Then to identify what is that monoclonal gammopathy due to, we do serum immunoelectrophoresis to see whether it is IgG or IgM with a kappa or a lambda. And once you know that, you need to quantify for your light chains, and that can be of great value, especially if you're planning to do something like a plasmapheresis, etc., to see for kappa lambda ratio. Okay, iron metabolism, serum ferritin denotes the iron levels in the body. Perfectly right. Iron is transported by binding with apoferrin, it's transported with transferrin. Iron is stored in the body is ferritin, free serum is, that's all correct. So iron is transported by binding to transferrin, which we've discussed in great detail. PNH, one of my favorite topics. Question is very simple. Sucrose lysis test, definitely not. It is FCM, flow cytometry, and we have discussed about CD55, CD9, PIGA gene, complement regulatory proteins, what happens in PNH, the different modes of presentation. Our own student's mother who had early morning hematuria diagnostic of PNH, somebody with a Budd-Chiari syndrome diagnostic of PNH, somebody with a pancytopenia diagnostic of PNH, somebody with cerebral vein thrombosis diagnostic of PNH. So all these different permutation combinations we have actually seen. Child had petechiae, splenomegaly. This is a pretty interesting question, because a patient has a pancytopenia here. Pancytopenia in a child may be with a spleen. So it can be AML or ALL when a child has a pancytopenia, though more likely in favor of ALL. But the fact that he has a spleen rules out AML. That brings us to ALL. And what is your first line treatment for ALL is essentially what they have asked. ALL, there are different therapies across the world, different regimes across the world. I'm not going to the individual details of the regimes, but primarily what we are trying to hint here is that the treatment has to be cornered around steroid, of course, which is the mainstay, with vincristine, which is very important. Also, it's important to have anthracyclines, that is your doxorubicin, daunorubicin. They are all part of your mainstay as far as treatment is concerned. Adult means, of course, we add cyclophosphamide. Children means we add L-asparagines, and then the complexities can increase and increase further depending on the individual case. And in adults, many times these are actually mixed up with regimes intermittently with methotrexate and cytarabine. So it's like one block. You actually give the patient steroid, vincristine, doxorubicin, and you give a cyclophosphamide. Next block, you give high dose IV methotrexate. So intermittently, you give these. So essential treatment not to be known in great detail, but to know what is the mainstay. So doxorubicin, nizorubicin, definitely not. And to know that cytarabine, daunorubicin is essentially for your AML, and this cannot be AML because of splenomegaly. IVIG, of course, not your ITP, radiotherapy of lymph nodes. This is not your lymphocyte predominant Hodgkin or something. So that's why this is the answer. Child is the biggest clue. If you don't know with respect to that, you can look for spleen, because spleen is not seen in AML. So that's how you identify. Plenty more questions are there which will be discussed in path. Aplastic crisis and PAROB19 in a patient with thalassemia or hereditary spherocytosis was asked. APTT intrinsic pathway was asked. Plasma cell to identify was asked. Not seen after ileal resection, you get macrocytosis and not microcytosis. Vitamin to be supplemented after gastrectomy, B12. So like that we've had so many questions. Okay, so hematology is as always very important, and please watch. Even if you don't watch any of the other subjects of mine from the videos, I would be very happy if you can watch hematology, and I can guarantee you that anyone and everyone watching hematology videos would definitely fall in love, because it is a divine science, extremely divine science. Please listen to that introductory video that I have done on hematology to understand what kind of a divine bond we have, and I feel so blessed to have been able to know the subject during this lifetime. Okay, neurology was sadly neglected for this time's exam. It's very unfair, I guess, that neurology, being such an important subject and having studied so much, was grossly neglected. Now, this was the only question, and this turned out to be a terrible question, also a very tough question as well. Here they've asked for a crossed hemiplegia. So, crossed hemiplegia, all of us know, is ipsilateral LMN, cranial palsy on one side and contralateral hemiplegia on the other side. So, then you have two syndromes here. One is called Foville syndrome and the other one is called Millard-Gubler syndrome. So, both are Pontine syndromes. And in Foville syndrome, it's a dorsal involvement. Millard-Gubler is slightly more ventral involvement. From time immemorial, we use these codes, FGH for Foville and FSH for Millard-Gubler. FGH means facial nerve palsy, gaze palsy, contralateral hemiplegia. Millard-Gubler means FSH, that is facial nerve palsy, sixth nerve palsy, contralateral hemiplegia. So, when you read this question, you don't know whether it is Millard-Gubler or Foville. So, the only way you can think is whether I mention the word gaze, because PPRF is getting involved in Foville, you will have conjugate gaze palsy. If they mention the word gaze palsy, then the answer is Foville. If they mentioned isolated lateral rectus palsy, because here it is the sixth nerve fibers that are getting involved in Millard-Gubler. So, if they mention seventh nerve palsy with isolated lateral rectus palsy, then it is equal to Millard-Gubler. If it is equal to conjugate gaze palsy in the question, then that means that it is equal to Foville. But it's very hard to say that way. But out of this question, I think the word gaze was there. So, I think that question they were looking for Foville. If gaze was not there and only lateral rectus involvement is mentioned, then the answer becomes Millard-Gubler. Okay. Patient after RTA when, yeah, this is ileal resection, you are never going to get microcytic hypochromic anemia, you are only going to get B12 deficiency or macrocytosis. This is the other question where you are having metabolic acidosis with hypokalemia, meaning that it is RTA 1 or 2. So, out of RTA 1 and 2, how do you differentiate? The moment urine pH is more than 5.5, straight hands on, it is RTA, RTA1, RTA1, RTA1. So, no doubt about that. Urine pH here is given as 9.4. So, don't have to read any other values for that matter. This is RTA1 only, and when you have RTA1, think of Sjogren syndrome first. So, this is patient suffering from RTA road traffic accident. So, he had an exaggeration. So, this is basically Brown's cord, hemisection of the spinal cord that they are basically looking out for. So, in hemisection of the spinal cord, you know that it is at the level of the medulla, that who is going to cross over, the corticospinal tract is going to cross over. Then, of course, the proprioception is going to come to the medulla and then cross over to the opposite side. The spinothalamic tract is going to cross over at the level of the spinal cord and then go up, which obviously makes it very simple, and this we have discussed 1000 times. So, you are going to lose pain and temperature not on the side of your hemiplegia, it's on the opposite side, so that's wrong. Proprioception should be lost on the right side, so that is wrong. Fasciculations are LMN, nothing. So, clonus is a part of UMN. So, right side you are having UMN involvement, right side you can have clonus. Simple understanding of what is hemisection. We have seen about central cord syndromes, we have seen about total cord transection, we have seen about hemisection. This is hemisection, that is Brown's cord. What is the most likely cause of death in a patient suffering from idiopathic pulmonary fibrosis? In a question paper which had a lot of good standard questions, this is a useless question, because every time in ILD you are having pulmonary hypertension leads on to respiratory failure. So, both are actually right. But what is the cause of death means, then respiratory failure is the cause of death. But then what is the complication? It is pulmonary hypertension. But if I have to mark an answer, I will mark respiratory failure primarily because that is the immediate cause of death. But what is it due to is pulmonary hypertension. Patient presenting to the OPD with 102 with foul smelling sputum and clubbing, acute onset clubbing, fever, eye spiking fever and all, everybody knows is basically equal to lung abscess, and that is basically equal to your necrotizing pneumonia, and you seeing air fluid level, and they had given a clear air fluid level on the CT or X-ray whatever. So, the answer is lung abscess. Okay, empyema doesn't generally have clubbing, empyema doesn't have so much of foul smelling sputum also. So, persistent fever after 5 days of giving antibiotics in a patient with pneumonia, you can think of empyema more. But to exactly differentiate between empyema and your lung abscess, you require a CT, and we have actually discussed about the important signs on a CT and how to differentiate between that. Okay, the double pleura sign and all that. Now, When to give bedaquiline was another question, where we have actually, not me, community medicine faculty Mohit sir has actually mentioned this very clear, and even I have mentioned in our videos on TB that we are now having multi-drug resistance and single drug resistance. Multi-drug resistance where we have short course and long course, and in short course we basically having bedaquiline, and to give that you need to be having multi-drug resistance, meaning that INH and rifampicin resistance, but fluoroquinolone naturally has to be sensitive. Then a question on a patient with epigastric pain radiating to the back. So essentially they are looking for pancreatitis, amylase, lipase, everything is elevated. Consumption of alcohol is also there. So this is probably a pancreatitis that is related to alcohol. What is the most important devastating deadly complication of pancreatitis? Of course, it is ARDS. And what is the other name for ARDS? Non-cardiogenic pulmonary edema. The moment you are having pulmonary edema, it is cardiogenic or renal or respiratory. Respiratory is ARDS, and that is called as non-cardiogenic. How do you differentiate? Based on your left atrial pressure or PCWP. High is cardiac, other one is non-cardiac. Nothing much to understand about this. It's very simple, straightforward, provided you know the core point. And that's how do you know the core point? By actually having a know-how of the topic. If you watch the ARDS video or studied ARDS from somewhere solidly, you know that this is going to be the answer. Because the moment you think of ARDS, infections come to your mind. After infections, there are certain specific causes. One very important cause is pancreatitis. Farmer with fever, chills, retroorbital pain, conjunctival suffusion, leg pain and all. I think enough and more evidence to say lepto. Enough and more evidence. Some people were asking why it can't be dengue, but I think when I read the question sent to me, it looks very specific. Right? Conjunctival suffusion has a high degree of sensitivity, specificity. Retroorbital pain can be for both, but thigh pain, leg pain, etc. more likely in favor of lepto. Kanagawa phenomenon, Vibrio parahemolytic is another question we've discussed. Typhoid, again, you have to do cultures. Anybody having fever for more than 96 hours in our country, that means 4 days have passed and patient is still continuing to have fever. You've already checked for malaria and dengue are negative. Two antibiotics that you have to start in these patients are one, doxycycline, because doxycycline does cover for your lepto, scrub and all that. Another thing that you have to be starting in this patient is cotrimoxazole, because our typhoid strains have good sensitivity to cotrimoxazole. But the moment 96 hours have passed, on day 5 you have to be doing cultures, and cultures is the best method. Catheter related bloodstream infection is another question that they asked on a dialysis patient. This is a slightly tough question. The question is basically to test out whether you know a simple point, a microbiology point, that if there is a biofilm formed already, then there is no point in giving antibiotics. You have to remove the catheter. I think that is the question they wanted. Generally, catheter related infection, if there is no biofilm present, we will go for one shot antibiotics and we will wait. Suppose not working and culture turns out to be positive and the patient is still continuing to have fever, we will remove the catheter. But here I think the question was biofilm present. So in that case, you have to remove the catheter. That is a slightly tough question. Then this question on dengue. Yeah. So dengue, what is the most important prognostic factor? In dengue, the most important prognostic factor as a clinical person, when you see the patient, if you know, if you worked in a ward, you'll know two things are very important: hematocrit and platelet. So if you are asking me to compare head to head, what can happen to a patient because of thrombocytopenia? Deadly devastating things can happen. But is it under your control? Yeah, definitely under my control. I can check the platelets twice a day and keep replacing platelets like that. But is this intravascular volume fully under my control? Unless and until I'm very vigilant and really planning to hydrate aggressively, it's not under my control. So hematocrit is very important. It's a huge impact on prognosis, because you can lose your intravascular volume like anything in dengue. That is the most important part. So essentially in dengue, the most important prognostic factor is always hematocrit. Though you may think platelet is also important. Yes, platelet is also very important, but hematocrit definitely goes above platelets. Irregular and no murmur was heard, and what would be the JAP finding in a person who is having irregular rhythm? That is AFib. And in AFib, do we have A waves? No, I don't have A waves. Then dyspnea, bilateral crackles and irregular pulse. This is another confusing question, but the crux is very easy here. Irregular pulse means you have AFib. Okay, AFib when the patient is having bilateral crackles means the patient is having AFib with heart failure. In a patient with AFib and heart failure, will you use beta blockers? You cannot use beta blockers. Anticoagulation, yes. Digoxin can be tried in heart failure, no doubt. Cardioversion, hemodynamically unstable, but not beta blockers. Beta blockers in acute decompensated heart failure, 100% not. Okay. HOCM dynamic auscultation, it increases on Valsalva. This is something that we have discussed in detail. So please see and please go and see the HOCM, not HOCM, it's called hypertrophic cardiomyopathy, because not everybody is obstruction, only 1/3 is obstruction. But essentially, to understand what happens with respect to preload and afterload, please go and see that. It's a very important discussion. And then of course, these two very important murmurs, your MVP murmur and HCM murmur, which increase with Valsalva, and what happens with respect to MVP, what happens with respect to HCM, Brocken, Bromarosine and all that, very important. Okay, Applying for a job ECG, this is another tough question, but let me tell you very easy that 7.41 is normal pH for you and me, we know that. But for the ABG question, 7.41 is alkalosis. Similarly, PR 0.21 is normal for you and me, but PR 0.21 for the exam is first degree heart block. It's as simple as that, okay? The moment it is more than 0.2, it is first degree heart block. Chest pain, BP is 130/90. Echo showed diastolic collapse of the atrium. Diastolic collapse, tamponade. So tamponade, pericardiocentesis. Again, there they asked on constrictive pericarditis. Here they are asking. I don't know what. Some people think pericarditis. How can pericarditis have diastolic collapse? How can pericarditis have palpitation? How can pericarditis have pulse rate of 101? That is okay. I mean explainable. But how can it have diastolic collapse? Nothing. Pericarditis means you can have maybe a mild pericardial effusion on the echo. Nothing else. Limiting the feeling, that is called diastolic collapse. Diastolic collapse of the ventricle means patient would come in hypotension. Here there is no hypotension. And this is the pseudomembranous enterocolitis image, just to actually finish off with things. Okay, so overall, if you ask me to gauge the paper as a medicine person who is interested in medicine, interested in integrated specialties, I would say that the paper is on par. It's a good standard paper. It's testing out a student with respect to his or her clinical sense and trying to figure out who are the best with respect to clinical medicine and trying to take them to the next level, which is very much acceptable. But from a student perspective, it is a reminder that all the time exams are not going to be like the ones we've had in the last 3 years. We have to raise our bar and try to perform better so that we can push on. So finally, if serious about PG and further a career in medicine, start early. That's why it's very competitive. It's extremely tough. Even after your course, it's very competitive. So many people are studying. How you create a market for yourself, that's the essential part. And means a demand for yourself. There's something in you that others can't replicate quite easily. And there is something in you that is slightly on demand. That's exactly what they are looking out for. So that's exactly what everybody is looking out for, whether you are in India or abroad. So try to start early, try to invest. The investments are at the early point. You have to invest at the early stage, not after so many years. There's no point in doing that. So, and don't crib over the fact that you come to a course where we are actually having to slog. That's true. We are going through so many turmoils of late, but essentially, I feel some way or the other you'll be rewarded. So if you keep putting the efforts and know your positives and negatives, that is the most important thing. Don't unnecessarily go with the fact that my grandfather wants to see me as a pediatrician. That's not the way. You need to know your positives and negatives, what kind of life you want, what makes you happy, and accordingly choose and understand all the subjects are actually speaking good enough. And again, to understand that the college is the most important part, which gives you the much needed fillip. Learn with difficulty to reap dividends later. That's the most important part. Don't be very laid back when you learn, like reading the notes passively. That won't help you reach anywhere. Don't take shortcuts. Shortcuts are of absolutely no use. 50% of the game is in your hands, how you identify the core and how you shoot. 50% of the game is in our hands, the people who are actually teaching you. So fix on your teachers, fix on your platform, and then follow it with conviction. Don't take any shortcuts. These revision videos or revision content of whosoever it may be will help you to get a much needed fillip here and there to just maybe boost your confidence. But the essential core concepts have to be studied in a tough way. And why is this exam important? Because the exam, on the positive note, gives us a huge opportunity to redeem or announce or escalate ourselves. Redeem means you're having something like a lost pride, not done well for your 12th standard NEET-PG exam. Now you want to really redeem yourself. This is the best way. It just kind of loads you with tons of confidence. Announce yourself on the stage. That's what I was looking for as far as this exam was concerned. Although I couldn't announce myself on stage. If you get a rank of say under 100, you really announce yourself, and everybody knows that you are like somebody who has a lot of stuff. And escalate for people who are already at a higher plateau. They can really escalate themselves and go up the bar and really kind of take their career to somewhere big. So that's what. And that when I talk about all this, many a times a question which I face is, where do I stand in the midst of all this? My answer is that you have to step up. You can definitely do that. You have to step your bar. Leave aside the competition. The moment you step your bar, then you know that you are in business. But the moment you're not stepping your bar and sitting in a hole and not doing anything to really push yourself forward, then it is always danger. But the ball is in your court. You can do that. There are the platforms. They will obviously help you. So if you plan that, okay, I'm going to raise my bar, I don't think there is anything stopping you. But if you don't really want to do that, then of course, what else can be done? Nothing. So for that matter, take this on a positive note. I think the exams that are going to come up are also going to be on similar lines, whether it be NEET, next, whatever terminology used to coin, whatever terminology we coin them with, ultimately they are testing for two things. One is speed to identify the core of the question, and two is your agility to shoot and to shoot right on target. So on that note, let's wind off.